Okay, all right, let's start with the yes. Hello, everybody. I'm Himun. Time flies and April is already here. Today we have another exciting teaching point recap with amazing line of ladies, Lara, Simi, and myself. Lara and Simi have been kind and active and valuable member of our group, and their presentations are outstanding. So I'm so proud to introduce our first presenter, Lara. Please give your introduction and start your presentation.
Yeah, sure. Hi, everyone. My name is Lara. I'm a final year medical student from Russia, and I'm now gonna pull up my screen. Okay, so this is gonna be a recap of a case that was presented by Shreyas on March 12th and was discussed by incredible members of CPS team, Sharmeen and Andrew. It started with a 58-year-old gentleman that presented to the hospital with 3 days of hemoptysis, which he described as specks of blood on tissue paper. And on review systems, he had no obvious oral lesions or bleeding from other sides. And also he denied any recent fever, chills, or weight loss. So from the practical standpoint, it is really useful not to build our differential around the hemoptysis, which basically means the bleeding anywhere from the trachea to the alveoli, but rather for the blood coming from patient's mouth to exclude some certain mimics of hemoptysis first. And the question we need to ask first, is it really blood that we're dealing here right now? Because it can be red colored sputum, for example, that can be associated with infections of Serratia that is notorious for producing red pigment. But on microscopy, it may look exactly like blood, but on microscopy, it's going to be lacking red blood cells. But this patient, he didn't look really inflamed. He had no fever, no chills, no signs of ongoing infection, and also he didn't have any risk factors for Serratia infection, which is basically any recent hospitalizations, placement of catheters, prior invasive procedures. So we place ourselves in a bucket of the bleeding. But if this patient is bleeding, we need to understand where this blood is coming from. And there are two ways how it can happen. It can be really true hemoptysis and the blood is coming from the lungs, but it can also be a pseudohemoptysis, a condition that is characterized by bleeding from upper airways and upper GI tract that can mimic that true hemoptysis. This patient, he had no obvious oral lesions to suspect bleeding from oral cavity or bleeding from other sides. He had no epistaxis or melena to consider the possibility of GI bleed. And also, our theory was further reinforced by the presence of crackles at bilateral lung bases on physical exam and the presence of respiratory distress in this patient. So we confirmed that the source of bleeding in this patient is likely in the lungs. But the next question we need to ask, why is this patient bleeding? So what do you think? You can put the answers in the chat. What is the most common cause of hemoptysis? Yeah, this is actually a tricky question because in general practice, the most common cause is going to be an acute respiratory infection like bronchitis. But the another important etiology to remember is tuberculosis, which actually is the most common cause of hemoptysis, not only in developing countries, but also worldwide. So if you remember, the patient presented with hemoptysis, which is bleeding from the lungs. And the evaluation of hemoptysis, it includes the confirming that this is true hemoptysis, which already done. And then we need to locate the site of bleeding and understand why is this patient bleeding from this site. So now at the second step, and there is one common mechanism how hemoptysis can develop, which is basically a presence of abnormal connection between the iris and the vessel. And there are two major ways to do that. First is the parenchymal processes invading through the vessels. And the next one is some vascular process invading into the lung parenchyma. and it can be anatomically divided into arterial, capillary, and venous processes. And the degree of hemoptysis can really help us prioritize one things over the others. If you remember, the patient presented with non-massive hemoptysis. He was hemodynamically stable, and he also was able to talk freely. So the arterial bleeding is highly unlikely in this patient because it is the most common cause of massive hemoptysis. And we kept it under differential the parenchymal processes as well as capillary and venous problems. The next question we need to ask, why is this patient bleeding? And of course, labs and imaging can help us understand this, but also the patient's background and his history can narrow some possible etiologies. First question we need to ask, does this patient has any known diagnosis that can predispose him to the hemoptysis that we see right now? Maybe it has a history of cancer of any location, not only lung cancer, because any cancers can metastasize to the lungs. Maybe he has a history of tuberculosis or some bleeding disorder that we know of. The next question, does the patient take any risky drugs that can explain or predispose him to the bleeding, like anticoagulants or antiplatelet therapy? The next question, what is the true duration of this patient's hemoptysis? And the tempo that we really should be worried about is the presence of progressive subacute to chronic hemoptysis, because this will shift our focus from some benign conditions like acute bronchitis to the presence of slowly growing process in the lung parenchyma, like lung cancer. And actually, it's been shown that up to 80% of patients with malignancy have a history of recurrent episodes of bleeding in the previous weeks. And the last question, does this patient have any distant symptoms other than hemoptysis? It can be any systemic symptom like weight loss, night sweats, or fever, but also it can be organ-specific symptoms. And the two organs that we need to keep in mind and watch out for is the heart, dysfunction of which directly affects the lungs, and also the kidneys that can be, for example, involved in pulmonary renal syndromes. And that's actually why every patient with hemoptysis should get a urinalysis. As for this patient, in the past medical history, what's caught our attention was the hypertension, which was uncontrolled because patient wasn't taking any medications for this condition, and also history of smoking for 30 years. In terms of the drugs, he really didn't have any significant risk factors for hemoptysis. In terms of duration, it was really an acute presentation. And even with history of smoking, we, at this point of time, weren't really worried about the possibility of lung cancer in this patient. And as for distant symptoms, his heart function was assessed with troponin, ECG, transthoracic echo, which were all normal, except for the presence of mild left atrial dilation. And chest X-ray also showed mild cardiomegaly, but no signs of active congestion. His renal function was also normal, and urinalysis was unremarkable. But the blood pressure stood out because it was significantly elevated at the level of 206 over 131. So in terms of further workup, CBC was done, which showed progressive anemia, but no thrombocytopenia and no signs of active inflammation. Chemistry was also unremarkable, and what's really important here is that the levels of ESR and CRP were also normal, as well as LDH. And coagulation panel was also within normal limits, so there weren't any signs of coagulopathy that can explain the current presentation of this patient. And the imaging studies were done, mainly the CT, which showed the presence of diffuse bilateral granulose opacities that were more prominent on the right side more than the left side. And also, it didn't reveal any presence of acute pulmonary embolism. So, with this presence of diffuse bilateral ground-glass opacities, progressive anemia, and the patient that is presenting with hemoptysis, we were really concerned at this point about diffuse alveolar hemorrhage. And since the CT isn't really specific and it can't confirm the diagnosis, a decision of doing bronchoscopy with BAL was made. So now I have a question for you. What set of findings would you expect to confirm the diagnosis of DAH? Set A or set B? You can just put the letter in the chat.
Very difficult. Set B.
Yes, Human, you're absolutely right. So uh, the findings that were found on BAL looked very similar to the set B with progressive increase in serial return of blood on subsequent aliquots, which is practically diagnostic for diffuse alveolar hemorrhage. So if we confirm that this patient is having diffuse alveolar hemorrhage right now, but the next question is, why does he have DAH? And there are three mechanisms how you can develop DAH. First is pulmonary capillaritis due to fibrinoid necrosis of alveolar capillary membrane. The next one is blunt pulmonary hemorrhage, which is characterized by diaperesis through intact alveolar capillary membrane. And the last one is diffuse alveolar damage, which basically is inflammatory bleeding, but without evidence of active capillaritis on histologic findings. So since the most common mechanism for developing of DAH is pulmonary capillaritis, which accounts for almost half of the cases of DAH, this patient underwent a series of serologic testing, which showed negative ANCAs, negative ANA, and negative cryoglobulins, and also negative anti-GBM antibodies. So then we moved and shift our focus to the right side of the CP solver schema for DAH, but this patient didn't have any signs of active ongoing inflammation. His level of white blood cells was normal. The ESR, LDH, CRP were also normal. So we really focused on the four buckets of non-inflammatory causes of DAH. And the mechanism for its development is the second mechanism that I thought about, which is blunt DAH, which is basically the leaking of red blood cells into the alveolar space in the setting of absent inflammation or destruction of the alveolar capillary membranes. And there are certain causes for blunt DAH. Two main problems is the pressure problem or the bleeding problem. In terms of pressure problem, the classic example would be the mitral stenosis, but it can also happen with acute decompensation and acute left ventricular heart failure, causing severe congestion of the lungs. And also this can happen in, for example, pulmonary veno-occlusive disease. In terms of bleeding predisposition, it can be primary problem like coagulopathy secondary to liver disease or drug-induced. And the third diagnosis would be idiopathic pulmonary hemosiderosis, which is diagnosis of exclusion. And to diagnose DAH, we need to first think about it with the presence of hemoptysis, dyspnea, and also possible findings of ongoing anemia. But although hemoptysis stands on the first as a leading symptom here, we need to remember that in up to 38% of the patients with diffuse alveolar hemorrhage, it can be absent even in the setting of severe bleeding into alveolar space. So the absence of hemoptysis doesn't equal to the absence of diffuse alveolar hemorrhage. The second step is we can suspect DAH with the presence of new bilateral ground glass opacities or consolidations on imaging. And there are certain specific patterns for diffuse alveolar hemorrhage on imaging, is that it can tend to be more centrally located rather than peripherally, and also it often spares the apical portions of the lung as well as costophrenic angles. And the next step, we can confirm the diagnosis of DH with BAL that will show either sustained or progressively more hemorrhagic aliquots. So this patient had no signs of inflammation, which put him in a bucket of planned DAH, and he also didn't have any evidence of bleeding predisposition. So we were really investigating the pressure problem and thinking about the hypertension-induced DAH. And there are certain proposed mechanisms how you can develop hypertension-induced DAH. First is endothelial dysfunction due to presence of large amount of vasoconstrictive active agents causing alveolar capillary injury. The second one is the venous hypertension that can be results of left ventricular dysfunction and venous congestion. And the last one is the arterial hypertension, because if you remember, the lungs have a dual blood supply with a small amount of blood coming from the systemic circulation in the form of bronchopulmonary arteries, which can directly transmit the systemic hypertension into the lungs. So in terms of the management, since this is the combination of markedly elevated blood pressure with signs of target organ damage, the hypertension-induced DH is considered a hypertensive emergency, and the mainstream of treatment is the antihypertensive therapy. And in these patients, after blood pressure control was achieved, it showed the resolution of pasties on follow-up chest X-ray after 2 weeks, which confirms the diagnosis of hypertension-induced DAH. So let's go over some key points of this presentation. First is the approach to hemoptysis. It includes 3 steps: confirm that it's true hemoptysis, localize the problem to the parenchyma or vascular, and the next, understand the cause. And the approach with 4Ds can really help us here. The next one is the etiology of hemoptysis. In general settings, more than 50% are caused by bronchitis, but worldwide, the most common cause remains the pulmonary TB. The next one is that the DH doesn't equal the diagnosis of vasculitis. And although the capillaritis is the most common mechanism of DH development, planned DH can also occur. And the last one is that the absence of hemoptysis doesn't exclude the possibility of DAH. And we need to suspect this diagnosis in the cases of new respiratory symptoms and new GGOs on imaging. And also the progressive anemia can help us. And to confirm the diagnosis, we need to do the bronchoscopy with BAL. And that's it for my presentation. And here are my references.
Amazing presentation, Lara. I think Abby was having question like how he was controlled with the BP. Do you know any like did he mention it, the presenter? How
No,
he
he didn't
chose?
mention it, but I expect
Uh-huh.
that this is hypertensive emergency. IV hypertensive, antihypertensive agents were used. I don't know namely which one.
Okay, that's excellent. Lara was having an exam and she was preparing this wonderful presentation. Really, good job. And our second presenter, Simi, are you ready? Please introduce yourself and let's start your presentation.
Hello everyone who has joined, and thank you for joining us today. And Lyra, I just loved your presentation, and it was great how you made the topic so simple for us. So I have a brief presentation for you all, and I'll just start sharing my screen. So can you guys see my screen? So today I will give you a recap of the case that was presented on 28th of March, and let's get started. So in this case, we have a 65-year-old woman who presented with abdominal pain. Her abdomen was distended. She had shortness of breath on lying down, which is also known as orthopnea, and she also had early satiety. So as for the abdominal pain, I have recently learned at CP Solvers that we have this approach of biphonemonic. V is for vascular causes, I is for infection, P is for perforation, and O is for obstruction. So that is how we approach abdominal pain. Then the patient also had abdominal distension. So how do we approach abdominal distension? We can think about the phases of matter causing abdominal obstruction, whether they are solid, liquid, or gas. And we are also able to distinguish between these phases of matter on some extent on examination. Like if there is gas, there will be hyperresonance to percussion. In cases of liquid, there is dullness to percussion. And I'll share with you a schema for a shortness of breath on lying down, that is orthopnea. So let's move to it. So when a person has orthopnea, the most common thing that comes to mind is cardiac cause. So left ventricular dysfunction can cause backflow of blood into the lungs, pulmonary congestion, and can cause shortness of breath, and more so when a person is lying down, as shown here. So, and the second cause we can think about for shortness of breath is something is wrong with diaphragm. So what can go wrong with the diaphragm? Either there is something primarily wrong with the diaphragm, such as it can get damaged by trauma, or there can be any problem at the level of nerves, that is the phrenic nerve, at the level of muscles, as in dermatomyositis, and between the nerve and muscle, we have this neuromuscular junction. So anything wrong with the neuromuscular junction, as in myasthenia gravis, can also affect the breathing process. And now the second cause we will think about is that anything that increases the load on diaphragm may also affect the functioning of the diaphragm and lead to dyspnea or shortness of breath or lying down. So what can increase pressure on diaphragm? Anything that is below the diaphragm or above the diaphragm can increase the pressure. Below the diaphragm, we have increase in the abdominal pressure, whether it be due to obesity or ascites. And above the diaphragm, we can think about lung, anything wrong with the lung, such as asthma, COPD, or tracheomalacia. So let's see what the examination findings of our patients showed. So the exam findings showed that there was distension and dullness on percussion, and dullness, this shows, the figure shows this distension and some fluid in the belly, which can cause distension as well as dullness to percussion. And also point of care ultrasound confirmed the presence of ascites. And now I'll just briefly discuss with you guys that how do we approach ascites. So we have this wonderful schema from CP solvers for ascites. And worst thing that comes to mind when someone has ascites is SAG score. So what is the SAG score? It is serum albumin to ascitic fluid albumin gradient, that is serum ascites minus the ascitic fluid albumin. So if the person has high SAG score, we can think of high SAG score as high portal pressure. So someone having high SAG score usually has high portal pressure. And the most common cause of high portal pressure is cirrhosis, but our patient did not have any stigmata of cirrhosis or anything like that. And now I'll just tell you briefly how portal pressure can cause ascites. So if we think of this as a capillary and peritoneum, so anything that causes increased pressure will just cause the leakage of fluid into this peritoneum and can cause ascites. And we can divide the causes into anything that is something wrong before the liver, in the liver, or after the liver. So before the liver, we have portal vein. And if we think of portal vein as a pipe, so what can cause increased pressure in a pipe? Either external compression to that pipe or obstruction in that pipe. So similarly, in the portal vein, either compression or anything that causes portal vein thrombosis can increase pressure. Anything within the liver parenchyma can also cause increased pressure on this vasculature and can contribute to ascites. And what can go wrong in the liver parenchyma? Either infection or inflammation, which we call hepatitis, or there can be any infiltration of a systemic disease, such as sarcoidosis. And now we'll think what can go wrong after the liver. So after the liver, we have hepatic vein, and hepatic vein can also get obstructed, just like portal vein. And this hepatic vein obstruction is what is known as the Budd-Chiari syndrome. Also, after liver, we have heart. So anything that causes increased heart pressure can be transmitted back, and this pressure will cause ascites. Now we'll move to the causes of low SAG ascites, and our patient was having low SAG ascites, so there I placed this tick here. So what can cause low pressure ascites? So I made these two figures for you. Okay. So either there is a capillary leak, that there are some holes in the capillary which can cause leakage of fluid, or there is a fall in the oncotic pressure which causes the leakage of proteins. So we can think about the organ-specific causes such as GI causes, as in pancreatitis. We can think about gynecological causes such as in MEG syndrome. In MEG syndrome, we have ovarian mass which contributes to ascites, and once this mass is usually removed, the ascites resolves. And in renal causes, when we have nephrotic syndrome, the protein is lost in the urine, so we have less protein in the body, so less protein in the ascitic fluid and low sag ascites. And we can always think about infection and autoimmune causes as well as cancer. But our patient was 65 years old, so anything autoimmune seemed less likely, and there was nothing indicative of infection, but we were still thinking about possibility of cancer. And three most common causes of ascites in US are usually three C's. Three C's stand for cancer, cirrhosis, and congestive heart failure. So let's move to the next slide. So what did the results in this patient showed? In this patient, we had low sag ascites, and whenever you have a low sag ascites, the next step is to check for ascitic fluid protein. If the ascitic fluid protein is more than 2.5, it shows that there is capillary leakage, like there are some holes in the capillaries, and so the proteins are moving into the ascitic fluid. And when the ascitic fluid protein is less than 2.5, we assume that there is less albumin in the blood and less albumin in ascitic fluid, as in hypoalbuminemia. And we got some tests done in this patient, and CD abdomen and chest, abdomen, and pelvis were done, which showed presence of some lung nodules, as well as some malignant, a mass was found in the liver, which on biopsy showed that it was a cancer. So in this case, we were dealing with low sag ascites, which was most likely secondary to cancer. And I'll just share my reference here. So please let me know if you have any questions or any thoughts or any final reflections. Thank you so much. And I hope you got to learn a little from this.
Wow, amazing. I love this colorful presentation, Simi. That's really wonderful. Anybody have a question? If there's no question, I guess it's my turn. I will. Um, okay, just a moment. Um, okay, can you see it? Can you see my presentation? Okay.
Yeah, we can see.
Okay, great. Okay, so okay. So my teaching point recap was case date was March 14, and case presenter was Uttara, and case discussant were Ravi and Prophet Reza. And let's just start it. Okay, so our main patient in this case was patient 4, a 70-year-old male with 4 weeks of leg swelling and fatigue. BP was 167 over 100, NT-proBNP was 16,000. But I'd like to give other patients, and there is the reason why I want to talk about this patient too. So let's look at patient 1, 70-year-old patient present with a low-grade fever, persistent malaise, and a night sweat lasting 2 weeks. Patient 2, a 28-year-old, suddenly developed left side weakness and difficulty speaking with no prior medical history. Patient 3, a 29-year-old, reports fever along with a pleurotic chest pain. Okay, so these are different manifestations, right? But guess what? The same disease or not? We'll see. Okay. Okay, let's go back to our patient 4. This patient was a 73 male, 4 weeks of leg swelling and fatigue. And the past medical history is very important, right? So aortic stenosis with TAVR 2023 was done, and diabetic, hypertension, and heart failure, preserved ejection fraction. And this person lives in a truck, maybe truck driver, and there is a cat exposure. What kind of organism are you thinking of when you think about cat? Can anybody tell me? Maybe, oh yeah. Bartonella, Lara, thank you. Yeah. Yes, and the viral, look at viral, BP 167, 100. When you look at the high BP, what are you thinking of? Anybody can put on the chat, but Robbie always mentioned that when you have a high BP, always look at kidney. So I'm going to look at the kidney of this patient, okay? Petechia on the scene and bilateral edema on the leg. It was really important point in this patient. And lab was showing the pancytopenia. Look at the PUN. It's 62 and creatinine was 4.17. It was baseline was like 1, less than 1. So, and NT-proBNP was 16,000. We can assume that it was heart strain somehow, right? And UA shows 3 plus proteinuria and hematuria. So hypertension and high kidney dysfunction and the proteinuria and hematuria, what do you think of? Well, answer is right here. Glomerulonephritis, right? The ejection fraction was 55%, LVH, and diastolic dysfunction. Linear biopsy showing the palsy immune crescentic glomerulonephritis. And the workup was done. ANCA was MPO-PR3 positive. And yeah, Lara and everybody, right. Bartonella PCR was positive. Bartonella quintana. So the diagnosis of this patient was, okay, let's look at, oh, moment. Bartonella endocarditis with pauci-immune crescentic glomerulonephritis. Okay, so let's look at the two criteria for effective endocarditis. Major criteria is blood culture positive for typical infective endocarditis organism will be like Staphylococcus aureus is most common. If you look at Viridian, what are you thinking of? You can put on the chat. And the Sterco's fulvus and Hasek and enterococci has to be positive, right? And then it draws 3 sets from separate site and 1 hour apart before antibiotic. And if negative, after 48 to 70 hours, repeat 2 sets. Wow, why is the separate site and draw 3 sets and repeat 2, 3 sets? Why? What is the reason? The reason is we have to avoid contamination, right? So if there's 1 is positive, 2 is negative, then it could be contamination, right? And also we have to make sure that antibiotic is working or not, right? And also, infective endocarditis has like foci keep sending the bacteria to our body. So we have to make sure that it's not keep sending bacteria. That's why we are repeating the blood culture. And also there is culture negative, which is famous organism, Coxiella, Bartonella, Brucella, Legionella, Mycoplasma, Chlamydia, and we have to make sure that it's not there, okay? And TE positive for vegetation. So TTD is first line for endocarditis, but TE is more sensitive for abscess, perforation, small size, pseudoaneurysm, and small vegetation. And then this was major criteria, right? And let's look at minor criteria. Okay, predisposing heart condition, like this patient had an AS, right? TAVR, which is prosthetic heart valve, and IV drug use, and fever has to be more than 38. So when you have acute, it's like really high fever and chill, and the manifestation is really severe. But if it is a subacute, let's say like someone had a dental procedure and it's a Viridian, then it could be just a subacute, a little bit low grade of fever, and then the manifestation is not that severe. And vascular, we have to look at emboli, right? Septic infarct, myocardic aneurysm. Someone had, in one case, there was a blindness in myocardic aneurysm, and ICAs, conjunctival hemorrhage, and genuine lesion in the palm and, sole, right? And immunology, let's look at glomerulonephritis and oslanose, all those immunologic. Okay, so I'm going to give you a question. Is it type 2 or type 3 hypersensitivity? What do you think? What do you think? Anybody? Yes, type 3, immune complex, right? So So glomerulonephritis immune complex is deposition in the glomeruli, damaging the glomeruli. So that's why proteinuria and hematuria, right? Also node is vasculitis on your skin, and lost spot is retinal hemorrhage. And the constant antigen stimulation can cause IgG and IgM complex, causing the positive rheumatoid factor. Okay, and then other blood culture not meeting measure criteria, echo findings suggestive but not meeting measure criteria will be another one. Okay. Okay. Okay, so why this patient has a leg swelling? So heart failure, even the preserved ejection fraction, is due to valvular regurgitation can be there, volume overload can cause edema, and glomerulonephritis, immune complex deposition, hypoalbuminemia, oncotic pressure is decreased, causing edema, and septic emboli, renal infection, right? If it is acute kidney injury, there will be volume overload, can cause edema, and Bartonella, vasculitis, endothelial injury, capillary leakage, and it can cause edema. And how about petechiae unseen? Septic emboli from infective endocarditis, from valve vegetation, emboli loss in skin vessel rupture, and it can cause petechiae. And immune complex mediated vasculitis can cause capillary damage and blood leakage and petechiae. All right, and let's go back to our patient. So, 70-year-old patient present with a low-grade fever, persistent malaise, and night sweat and lasting 2 weeks. So, what do you think? Is this subacute or acute? Because I'm going to give you a hint. This patient was done the dental procedure. Anybody? Lara, what do you think? Is it subacute or just acute? Okay, yeah, it is subacute. So it's lasting 2 weeks, and the symptoms not as severe as the acute, but it can usually caused by viridian. The acute is usually caused by Staphylococcus aureus. And let's look at patient 2. 28-year-old suddenly developed left side weakness and difficulty speaking. No prior medical history. What do you think? What is happening in this patient? Um, yeah, septic embolus. So what is he having? Yeah, he might have a like stroke, right? Because of the septic emboli causing the stroke, and this person can have left side weakness, difficulty speaking. And patient 3, okay, Lara, can you unmute and let's look at 29-year-old report fever along with the pleural chest pain. What do you think? What is it this patient is having?
Yeah, I'm thinking that he probably has right-sided endocarditis causing septic emboli to the lungs.
Yeah, if it is the right side, what kind of valve are you thinking of?
Well, I think tricuspid valve.
Yes, and then we can look for their social history. What can you say?
Possibly intravenous drug use.
Yeah, intravenous. Yeah, he was IV user. So yeah, that's good job. Yeah. So this is the like how we have a manifestation of infective endocarditis, and why is not okay? All right. So this is okay. So I'm going to this last slide is for empiric treatment of infective endocarditis. For native valve like vancomycin and ceftriaxone, really vancomycin cover MRSA and ceftriaxone can cover gram-negative HASIC and Staphylococcus. But prosthetic valve we use vancomycin and gentamicin, not the ceftriaxone. Do you know why the reason? Because gentamicin, the plastic valve is the unique character of biofilm conformation, forming the biofilm. So we have to really penetrate biofilm, and we need a synergy reaction with vancomycin and gentamicin to affect the biofilm, and really focus on prosthetic valve infection organism like enterococci and Staphylococcus aureus. And the rifampin is really excellent in the penetrating biofilm. But let's think about it. We can use vancomycin and rifampin for 6 weeks, but gentamicin is only for 2 weeks. Do you know the reason? Oh, sorry. Go back to, how do I go back to? Well, actually, sorry, I think I don't know how to go back to. But anyway, yeah, why do you think is the reason why gentamicin is just for 2 weeks? Yeah, gentamicin has a nephrotoxicity, right? And this person was having a very glomerulonephritis, so we shouldn't use it for just for 2 weeks. And since we have a confirmation of this patient having Bartonella, what antibiotic is really good for? I gave it, but it's a test. So what kind of antibiotic can we use for Bartonella? Anybody? Doxycycline can be used, and yeah, Simi, thank you, doxycycline. And also because this patient was a prosthetic valve, right? So gentamicin can be added, or rifampin can be added to penetrate the biofilm. So yeah, this is my presentation. I hope you had a great time to learn. And yeah, so just hey, how do I like, okay, how can I? Okay, so yeah, so I think this is our presentation, and it was really exciting to have a presentation with all of you guys. Lara, Simi, thank you so much for a wonderful presentation, and people who are in here, thank you for being here, and also yeah, also spring is here, right? Yeah, April is spring is here with a lot of hope and new fresh start. So I hope you guys have a wonderful spring, and yeah, and have a wonderful day. Thank you for being here. Bye.